Good afternoon, and welcome to the Washington Medical Commission webinar series as part of Patient Safety Awareness Week. Today, I am joined by WMC Chair Dr. Jimmy Chung, Commission Member Dr. Diana Curry, Mahi Zuru, WMC Equity and Social Justice Manager, and Mike Farrell, WMC Policy Manager, to discuss the impacts of discrimination on patient safety and how the WMC is addressing this issue. Before I turn the webinar over, I would like to take care of a few housekeeping items. We encourage you to ask questions throughout the presentation, so look for the question chat box on your webinar portal, and we will do our best to address your questions at the end of the presentation. We are recording this webinar, and the on-demand version and slide deck will be available on our website within the next few days. Please feel free to share these resources with your friends and colleagues. And with that out of the way, I will turn it over to Dr. Chung.
Thank you, Jimmy. Thank you, everyone, for joining us today for our presentation, How Discrimination Affects Patient Safety. When we talk about patient safety, we often think about harm caused by medical errors, complications such as falls and pressure ulcers, adverse reactions to medications, or plain negligence. However, today, as part of Patient Safety Awareness Week, we want to highlight discrimination, a cause of patient harm, is often overlooked but remains a significant determinant of healthcare access in our society, and is a major focus within the Washington Medical Commission. We hope you will learn how discrimination affects patients, the care that they receive, and their outcomes, and how discrimination is not only wrong, but it's a violation under the Uniform Disciplinary Act in the state of Washington. We'll first begin by briefly explaining who we are and what we do. The Washington Medical Commission is an organization whose mission is to promote patient safety, enhance the integrity of the profession through licensing, discipline, rulemaking, and education. Our vision is to advance the optimal level of medical care for the people of Washington State. The commission is made up of 21 governor-appointed members, of which 13 are physicians, 2 are physician assistants, and 6 public members. We have oversight over licensing and regulatory oversight of 35,000 MDs and PAs. There is a staff of 52 members who support the work that we do, and we are an independent commission from the Department of Health. To go over our agenda for today, I'm going to hand it over to Mahi Zuru.
Thank you, Dr. Chung. So today we'll talk about the Commission's discrimination healthcare policy, and Mike will go over the policy enforcement and action, and Dr. Curry and Dr. Chung will close out with real-life examples and case studies of discrimination in clinical practice. So what does discrimination mean? It means unfair treatment. Unfair treatment because of the way you look, talk, or move. And discrimination is an umbrella term used to describe all types of unfair or unequal treatment. But we can separate them in 2 main areas. So the first is unintentional unfair treatment or implicit bias, and the second is intentional unfair treatment or explicit bias. So we have unintentional implicit bias and intentional, which is explicit bias. So implicit bias is a subconscious feeling, perception, stereotype that has developed as a result of prior exposure to culture, and they can be negative or positive. And they're hard to identify because some beliefs or the same beliefs are held by the provider as well as the general public, everyone. So a real world example can be, say, a hiring manager subconsciously not selecting applicants with disability because they assume they'll take more sick leave. And another clinical example could be women who experience pain. So it's automatically considered less severe because women exaggerate everything. So they must also exaggerate pain, which is not true, by the way. So that's implicit bias. An explicit bias is more easily identified because they are conscious decisions that are made. So provider not listening to the symptom of a person with disability because they think they're less deserving, and not ordering diagnostic tests is an example of an intentional decision-making bias. So according to a study published in the Journal of American Medical Association, 1 in 5 adults have experienced discrimination. So Dr. Chung will review a case study later, but 5 of the most commonly reported types of discrimination were based on race and ethnicity, educational or income level, weight, sex, and the last one was age. And discrimination is a concern in healthcare because it impacts the quality of healthcare we receive. So what does discrimination look like in healthcare? Again, discrimination can look and take many forms, and it's present all across different specialties. And discrimination in healthcare setting include, again, dismissing a patient's symptom or health concern, offering different types of treatment based on the patient's types of insurance, or not ordering diagnostic tests and procedures. And there are, again, many types of discrimination, but in this policy, we call out age, race, ethnic origin, citizenship, immigration status, housing, marital arrangement, disability, including all developmental learning. And this is not an exhaustive list, but we have many of them on the policy. So the impacts of discrimination in health are well documented, but our investigation process and organization did not have a policy or investigation process in place to remediate or correct actions by the providers or our licensees. So recognizing this gap that threatens patient safety, we made many changes to the commission. And among them was the creation and passing of this discrimination healthcare policy, which passed in March of 2022. So in this policy, WMC recognizes discrimination as a social determinant of health. So discrimination violates our fundamental human rights because it prevents our access to quality healthcare. And discrimination causes health disparities. So with this policy, the Commission recognizes discrimination, both implicit and explicit, as a violation and takes appropriate actions, which mirrors the other disciplinary actions ranging from education to suspension. And Michael will review the discipline and action portions in just a few minutes. And I also want to highlight this discussion of discrimination is not just an issue we in Washington State are working on. So there's also work happening nationwide. The FSMB, the Federation of State Medical Boards, came out with a policy statement that calls out systemic racism, discrimination, and structural inequalities as a factor that contributes to health disparities. And they commissioned a diversity and inclusion work group to come up with the current reports and have actionable recommendations. So the interim report will be released soon, but our very own commissioner, Dr. Curry, is part of the work group to champion the cause of discrimination. So thank you for that. Next slide. Thank you. So I want to make sure we're on the same page when we talk about the impact of discrimination and the consequences it has on people's lives. So African American women are 3 to 4 times more likely to die from pregnancy-related causes than white women. So this happens because of untreated pregnancy conditions, poor prenatal care, but ultimately it's Black women's voices not being heard. Timely actions not being taken during emergencies, symptoms remaining ignored or minimized, and that's what discrimination is. And Black people are also undertreated for pain. A 2016 study found many white medical students wrongly believe that Black people have higher pain tolerance than white people. And these are medical students. So of all the participants, 73% of them had at least one belief about biological differences between races. So examples of these beliefs include Black people having thicker skin, less sensitive nerve endings, or having stronger immune systems. And the researchers note that these beliefs are centuries old, and some doctors have used them to justify the inhumane treatments of slaves, but these myths have an impact today. What's even sadder is that these implicit beliefs are being applied to children. So researchers have also found that Black children with appendicitis are less likely to receive appropriate pain medication when compared with white children. And the same is true in research of people with recurring cancer. So no pain treatment. And Black and Latinx children are also less likely to be admitted to emergency care. Again, another literature review, another study. So when they are presented, when they present to the ER with the same symptoms, Black and Latinx children are less likely to get blood tests, CT scans, X-rays when compared with white children. And the researchers say that these differences cannot be explained by social or economic or some clinical factors. And the only unaccounted factor is, or still is discrimination. And differences in emergency care, again, apply to adults as well. Like an 11-year-old study that came out in 2022 or 2020 found that Black patients were 10% likely to be admitted to the hospital when compared with white patients. And same study also found that even when Black people are admitted to the hospital, they are 1.26 times more likely to die in the emergency department. And then Asian Americans are also undiagnosed for alcohol addiction, another disparity. A 2016 study suggests that doctors are less likely to diagnose alcohol addiction in Asian Americans compared to white people, despite having all of the same symptoms. And this may occur due to the model minority stereotype, which frames Asian Americans as successful and self-reliant, therefore less likely to have any addiction problems. So this implicit bias, this stereotype, leads doctors to overlook signs in Asian American patients when they really need help. And then the last one on here, older adults may get overtreated or have untreated or have treatable illness dismissed as a future of old age. So, and this is this is called ageism or age-based discrimination, and it can manifest in many different ways. So for older adults, discrimination may lead physicians to dismiss treatable illness as a future of old age. For example, complaints of pain may be ignored as a normal part of aging. Getting old should not hurt. So early diagnosis could have caught like a treatable condition or even cancer, leading to better outcomes. On the other end, older adults may also get overtreated, and they're ordered unnecessary tests and unnecessary treatment plans or even surgery, which causes pain and trauma. And older adults may also feel dismissed by their providers who are impatient, unengaged, and unresponsive to issues brought up their older patients. And they're more likely to assume that an older adult is cognitively impaired. And so they don't even bother to explain details of the diagnosis or tell them what the prescribed medications should do or how to even take them. So, and the same sentiment is also true for people with disabilities. And numerous studies have documented physician bias towards people with disabilities. And treatment is being withheld when the hospital or state is not in a crisis standards of care. So physicians' biases are seeping into the actual treatment plan of older people and also people with disabilities. So as you can see, the consequences of discrimination are vast, and it impacts many people in one form of or another. So I will now pass it off to Mike to explain the Commission's action and discipline process for providers who have complaints of discrimination.
Thank you, Mahi. Hi, everyone. I'm Mike Farrell. I'm the Policy Development Manager with the Commission, and I'm going to talk briefly about the last section of the policy, which is Commission action, or WMC action. And this section states that it's unprofessional conduct for a physician or PA to engage in any of the conduct that Mahi described because it presents a risk to patients. And this is negligence under RCW 18.130.180 because it's below the standard of care and it either can harm a patient or present a risk of harm to patients. But in preparing for the webinar, it occurred to me that there's another possible basis for action by the Commission, and that is that discriminatory behavior can constitute abuse. The Commission has a rule on abuse, and one of the definitions of abuse is on the slide there. And it is conduct that unreasonably demeans, humiliates, embarrasses, threatens, or harms a patient. So two possible bases for Commission action. Next slide, please. The policy then states that discriminatory behavior can encompass a wide range of behaviors. It's a long continuum, and I demonstrated illustrating the continuum here with the arrow. At one end, you can have conduct that shows implicit bias or unintentional behavior, and at the other end, intentional behavior. And in between can be insensitive behavior or even reckless behavior, reckless disregard of the patient's dignity as a person and as a patient. In between, I put down some sanctions that the Commission could consider if they get a case, if they're evaluating a case of discriminatory behavior. So at the left end, the more mild end, if the behavior is unintentional, maybe insensitive, the Commission could want the physician or PA to undergo education and guidance, and that would be the extent of it. If there's a little more to it, the Commission could consider requiring the MD or PA to issue a letter of apology to the patient, or actually to anybody who was affected. If there's a concern that the behavior could indicate that there's a mental or physical issue with the licensee, the Commission has the authority to ask the licensee to undergo a mental or physical examination. And if the behavior verges on to recklessness or even intentional behavior, the Commission can impose a harsher sanction, such as a restriction of practice. And if the Commission deems the licensee to be incapable of being rehabilitated, then the Commission can take the most drastic action and remove the license. I'm speaking generally here. The facts of each case will determine what sanction is appropriate. Next slide, please. Finally, the policy, the Commission's policy points out that there are other laws that can be at play, and this is not an exhaustive list by any means, but I just wanted to point out three that deal with discrimination and prohibit discrimination. The first is the Washington State Civil Rights Act, which was enacted way back in 1949, and it prohibits discrimination on a number of areas, including race, creed, color, national origin, citizenship, immigration status, sex, marital status, sexual orientation, age, and military status. And it also prohibits discrimination against honorably discharged veterans, families with children, and people who use service animals. The Act has a declaration of rights for people in certain situations, including employment, public accommodation, real estate transactions, credit transactions, insurance, commerce, and breastfeeding in public. And finally, the Act establishes the Human Rights Commission. I listed a couple of federal laws. There are more than this, but I listed a couple of the major ones. The Federal Civil Rights Act of 1964, which prohibits much the same conduct that the state act does. And then, of course, any discriminatory behavior could run afoul of the Americans with Disabilities Act. So that concludes my presentation. I'll pass this on now to Dr. Diana Curry, who will talk about discrimination from a clinician's perspective.
Okay, hi everyone, Diana Curry here. I'm an OBGYN and a member of the commission for the last 4 years. So I wanted to give some sort of real life examples to really ground what we're talking about in day-to-day, details of a clinical encounter. I think that the most common kinds of discrimination that we find are unintentional. So some examples of that might be a clinician is just simply uncomfortable with a type of patient, for example, a transgender patient, or maybe an elderly female patient. So take an OBGYN who just feels uncomfortable trying to do a pelvic exam on an older lady or a transgender patient. So that's sort of not really intentional discrimination, but because of their own discomfort with maybe that population, they're worried that they'll be offended or they'll be uncomfortable, et cetera. But that's really a type of discrimination in healthcare and providing less than the standard of care for that patient population. Sometimes there's things like assumptions made that we don't even realize. For example, 85-year-old women don't have sex, therefore they don't need a pelvic exam. And I can't tell you how many of us in GYN have found cancers down there because nobody's examined a patient for 20 years. Or there's been lots of studies on pap smear screening and cervical cancer detection in the lesbian population. Somehow it's assumed that because somebody's a lesbian, they are not at risk of cervical cancer. Another example of sort of an assumption that isn't really meaning to be harmful, but ends up being harmful. So really important to have clinicians aware of what they're doing in these kinds of cases and aware of their assumptions. Some examples of what might be considered a little bit more insensitive or kind of careless behavior are often found in cases where somebody has a health condition that's related to, for example, obesity or substance use. And there's this sort of creeps in this idea that somehow they're to blame for their medical condition. So we can call it fat shaming, but it's not even quite that level in some cases. It's just this kind of implicit or subtle indication that maybe if the patient just stopped eating dessert, they would get better, or stopped using drugs, et cetera. So it's maybe not overt, but it's enough for patients to feel it. So they'll come out of an encounter with a doctor who has that kind of assumption and that sort of attitude, and they will feel bad. They'll feel shamed. They'll feel embarrassed. And again, that is a violation of one of the laws that Mike referred to, the abuse law. You cannot do anything, have any behavior that unreasonably demeans or embarrasses, humiliates a patient. Examples of intentional discrimination are not as common, but things that I've seen in my practice over the years are things like a patient who, for example, had a medical abortion, had a complication, came into the ER, and you have the attitude of the physician, well, you did this to yourself, it's your own fault, you had an abortion, that sort of thing. That's just not okay. We all know that. Or I have seen this too, somebody who's had an abortion in their past and now they're having a miscarriage or a pregnancy complication and they get blamed. Oh, well, if you hadn't had the abortion, this wouldn't have happened. That type of behavior is just never okay, and that is an example of discrimination at sort of the intentional level. Certain patients who may come from the Department of Corrections or may have substance use issues may not get treated as thoroughly or adequately because the provider is frustrated with them or angry at them or feels they don't deserve the care. They brought it on themselves. So these types of human reactions in the clinician can creep into the professional setting. And while maybe that person's tired and they've seen that same drug-using patient 5 times for the same skin infection from their needles, they're not allowed to get frustrated and angry and take it out on the patient. That's just against the law in this case. That is discrimination and violates the Uniform Disciplinary Act. So those are just some of the experiences or situations that I've seen where discrimination has crept into the clinical encounter. And as the policy that the commission has written, as Mahi so eloquently discussed, we are now recognizing that these type of things really do cause harm, and we're trying to educate physicians about it, clinicians about it, and when needed, discipline physicians about it. So now I'm going to hand it over to Jimmy.
Yeah, thank you. I think one of the difficulties for physicians and PAs and clinicians as a whole, because I would say the majority of us, if not most of us, want to do what's right for the patient. Oftentimes we may find ourselves in a situation where we don't recognize that we have committed this discrimination. As previously discussed, there are unintentional discrimination that occurs, and so a lot of times we have to rely on the patient's perception of what did they feel was the discrimination, and learn from that. One of the studies that I had previously referred to is this one, the JAMA article. This came from University of Michigan, where they asked patients if they had experienced discrimination. And as she mentioned, 1 out of 5 had said that they had experienced discrimination, and there were multiple different descriptions of that. Not surprisingly, the overwhelming majority of those who claimed that they had experienced discrimination, 72%, said that they had experienced it more than once. Again, not surprisingly, you would find that those who are more likely to experience discrimination are either female, of a low income, and higher for Hispanic, Black, or other races than whites. Next slide, please. In the same study, they looked at some other factors that were self-reported by the patients. These included the perception of discrimination due to a self-reported poor health, assumed so that the clinicians assume that if somebody is already in poor health, that they are treated differently, or perhaps may feel guilty about their poor health, or just the stigma of poor health coming along with the care that they receive. Weight and age, as previously mentioned. Insurance status is an issue that was widely discussed, whether or not they have the ability to pay. Again, it may not be that they actually received poor care because of that, but that the patients felt that their inability to pay for their services made them feel discriminated. Others included history of substance use. I think we see that as clinicians a lot in our practice, where if somebody has a history of drug use, they are automatically thought to be a problem patient, and that we would have to adjust their pain medications, or that they would be more likely to be demanding, etc., which again would make the patient feel uncomfortable. Other medication use. If patients are on a lot of different medications, they are also made to feel like there's something wrong with them, that they would not receive the care that they should deserve. Mental health status is becoming more probably because more people are able to share their mental health or recognize their mental health issues and share that with their physicians, who traditionally and admittedly most non-mental health physicians and practitioners are not comfortable with dealing with those patients. Some patients reported that their signs of their lifestyle, such as long hair or tattoos, made them feel that they were discriminated, and obviously the inability to speak English can play a big factor. Next slide, please. Another fascinating study was this one that was also in a JAMA article, this coming from University of Pennsylvania, looking at discrimination that was reported on online reviews. Now, some of they used an AI type of algorithm to collect thousands of online reviews of clinical care that patients had received. Some of them may have been discrimination against the physician or the clinician, but the great majority of them were found to be discrimination against the patient. So using that data, they were able to highlight the patient's perspective of the discrimination that they had felt, and then categorize them between different individual behaviors and institutional or systemic racism. And then they were able to recognize 6 categories of recurring patterns. One is commission, which is just overt discrimination, either through harassment or obvious differential treatment. The act of omission, which includes things like delay in payment, which was already previously mentioned, long waits in the waiting room, not considering a diagnosis because of a misconception about their race, dehumanizing acts, being impolite or being ignored, being disrespectful, and just not feeling like they're receiving the compassion that they feel that they deserve. Stereotyping, which includes assumptions, the acts of microaggression, which I think those of us who have experienced racism are very familiar with, and sometimes can be unintentional, but again, makes the patient feel uncomfortable to the point where they may not be telling the truth or seeking health care that they deserve. Using people had written on the online reviews even examples of caregivers using words like, well, you people, and describing generalizations of their background. Intimidation, such as bullying, intrusion into their private space or personal space, using fear or belittling the patient, making the patients feel uncomfortable while they change into their gowns, and so forth. And then unprofessionalism, including being condescending, overly casual, because you assume that people of that either color or race are not educated, lack of attention to detail, or having a negative attitude while treating those patients. And so the importance is to recognize that there's also with this type of experience that patients have reported, that sometimes it's not just a individual's act of discrimination, but systemic discrimination. So I'll describe a couple of other examples. One is an NYU study from 2019 that showed that between 2 different Chicago neighborhoods, the life expectancy in one neighborhood was about 60, and less than 10 miles away, just literally the next zip code over, that neighborhood had a life expectancy of 90. And this had correlated exactly with the racial mix. Even though they're getting their care in the same institutions, the result of the discrimination that the population experiences, and not just the individual patient, but the population experiences, can be significant. And And I would share also some personal experiences. When I was in medical school, I went to medical school in San Diego, where a significant number of patients who show up at the emergency room at the main hospital, the university hospital, there are Latino and non-English speaking. And there was literally even the professors would comment that, oh, they just came across the border to have their baby and to get free healthcare and then leave. And so I personally noticed, and obviously I don't have data to back this up, but I personally felt like that we tended to yell more at those patients, especially when they're giving birth and they're trying to push. We would yell at them more. They're less likely to get an epidural, less likely to have, and unfortunately this was before the days of when we actually had interpreters and translation services readily available. So a lot of the yelling, I think, had to do with the fact that they didn't speak English and the caregivers didn't speak Spanish. But nonetheless, I think there was a significant discrimination in terms of the quality of the care that we provided. And from a surgical perspective also, because I think the surgeons knew that if you're Spanish speaking and non-English speaking, you're less likely to understand what a consent form is. They would be glossed over, have them sign quickly, and then taken them to surgery, really without them understanding what's happening to them. And so having witnessed that, I know that these things happen. None of the surgeons or the physicians that I worked with were, quote, bad people. They just were working in a system where this type of discrimination was allowed to happen, and we didn't have the tools to help us get through that. So that was, of course, decades ago, but I think a lot of those issues still remain. And we at the Medical Commission would recognize that these are opportunities for us to help our physicians and PAs practice with more compassion and more without discrimination when treating these types of patients. So next slide. I think that may be the last one. So I think just finally, I'd like to add that while discrimination can lead to a poor patient experience for the individual, as well as inequities in outcomes for the community, the act of discrimination does not have to lead to a bad outcome per se for it to be considered a violation. The act in and of itself is a violation, even if the patient ultimately had a good medical outcome. If there is a complaint that's validated of discrimination, it would still be considered a violation within our purview. And finally, we should all recognize that the effect of discrimination extends beyond just that one experience, that a patient experiencing discrimination during a healthcare visit may well lose trust in the provider and the health system as a whole, and may be disincentivized to seek medical care in the future, avoiding preventive care, and ending up in high acuity situations that not only increases risks for the patient, but also the cost of care to the system. So on that note, I'd like to thank everyone for joining us today and for your dedication to the safety of our patients. Despite much effort over the past many decades, patient safety still remains a significant issue in the US health system. Washington Medical Commission remains committed to improving the patient experience and reducing the risk to patient safety through education, partnership, and advocacy. I'd like to thank Dr. Diana Curry, Mahi Zeru, and Mike Farrell, and Jimmy Bush for their tireless work on protecting the public and their work on discrimination in healthcare. I hope this webinar was able to provide some insight into how discrimination, both unintended and overt discrimination, can lead to patient harm and health inequities for our population. So thank you very much.
Thank you, and I hope everyone will join me in a virtual round of applause. I really appreciate this wonderful presentation. So please, if you have any questions, use the question box to ask those. And while people are formulating their thoughts, we do have a question that was submitted earlier, in that Dr. Curry spoke about unintentional discrimination, and that this may occur because the provider is unfamiliar or maybe even uncomfortable with their patient. So does anyone on the panel have any suggestions as to how a provider can address this issue or their behavior?
I'm happy to speak to that. So I think that it is fine for a provider to see a patient of a type that maybe they haven't seen before. That's going to happen. And acknowledging it and sort of owning up to it, not trying to be, oh, I know everything, right? So patients, we get a lot of complaints from patients say, oh, the doctor acted like they knew everything. They told me I felt like an idiot. You know, they went to medical school, I didn't, blah, blah, blah. But really what it comes down to is patients know their bodies best. And if you can own up to the fact that maybe you haven't seen their condition before, but you're right there with them, you listen to them, you want to help them, you'll research it if you can. Please tell me about your situation. Tell me what you've tried before. We can learn about our patients' conditions from our patients to some degree. We don't have to know all the answers. Patients are frequently looking for partners and partnership in healthcare. They want us to help them. They don't necessarily want us to tell them everything. They're okay with that. Everybody understands that things are complex and complicated. And so yeah, I would just say if you're uncomfortable, if you're not sure, ask. Don't assume. Again, you know, don't assume somebody's not having sex or having sex. Don't assume somebody's whatever. Assumptions, we know about assumptions. They don't lead to a good situation. So yeah, ask.
Yeah, I couldn't agree more with that, Dr. Curry. I think the reality is at this day and age, you know, doctors really, as you said, are partners in the patient's own journey towards health and wellness. And we shouldn't make the patient feel like we know everything. And that if you feel uncomfortable with something, that is a signal for you to be honest. I remember seeing a patient before surgery who was deaf and blind, deaf, dumb, and blind, and had to communicate through an interpreter and a machine. And I had never dealt with a patient like that before. And obviously, I'm not going to intentionally discriminate, but my own discomfort with not being able to communicate the way I'm used to with a patient like that would obviously most likely lead me to leave something out or make a decision that perhaps wasn't the best for that patient. And so, you know, I just expressed how uncomfortable I was. And fortunately, the patient was used to that and just smiled, and through his interpreter, made me feel more comfortable. And it took a little extra time and a lot more dialogue, but eventually I became more comfortable with that situation. And at least I feel like I was able to provide good care for that patient. But again, when you feel that discomfort, that is the signal for you to not back away, but actually open up further and say, I'm really uncomfortable with this. I've never done this before. Or, you know, I've never treated a trans patient before, or I've never you know, I've never taken care of a patient who, you know, is like you. I think it's perfectly okay to be open like that. And from that medical commission perspective, when we do get complaints like this, I have to admit, the majority of them have to do with communication. And the complainant is usually a patient or a family member who says something that eventually boils down to, if only the physician or the PA had just communicated better, they would have had a better understanding. And so I think the lesson there that for that question is just openly communicate and be honest.
I might just add one thing, which is that never forget patients are the experts at their own body. They have the lived experience. We don't. We think we know a lot because we went to medical school and we understand the anatomy and physiology and all of that. But honestly, the lived experience is the primary factor when it comes to patient-centered care. And then I just want to say one other thing that I think happens a lot, which is this day and age, patients come in with their Dr. Google list of things that they've looked up. And there is a tendency to get annoyed, okay, if they come in with 50 pages of stuff that they've read and they want you to look at. But again, lean into that. So whenever you find yourself getting annoyed, lean into it. Ask yourself, why am I feeling this way? And try to redirect and embrace it, because that's going to lead to a better communication, a better experience for the patient. And both of you will hopefully come out learning something. Yeah, so we get a lot of complaints around that too. So.
Just to add on to that, if you want to increase or advance your understanding of DEI principles, diversity, equity, and inclusion, there are many CME opportunities. The American Academy of Physician Associates has a series on bias, how to talk about race, mental health, you name it. So any kind of DEI opportunity, it's out there. Look to your local medical associations, university seminars. So there are many opportunities to increase your DEI knowledge as well.
Well, I would like to thank you again for presenting this valuable information, and thank you to everyone for attending and participating. I hope everyone has a wonderful week and remembers to take care of themselves. Take care, everyone.